post-intensive care syndrome, and there's a lot of research going on in that field right now. There's kind of three main components to post-intensive care syndrome. One is myopathy, muscle weakness, ICU-acquired weakness, critical illness myopathy. It has different names, but it means all the same thing. And these symptoms of post-intensive care syndrome can last for a long time. Even a year later, after the patient has been discharged from the hospital, they can still have weakness. And then the other symptoms are cognitive changes, and then lastly, mental health issues. So, and they can have issues with their family. Families have a hard time dealing with it, and these are long-term effects. The worst risk factor for developing post-intensive care syndrome is on people who are on the vent for 7 days or longer, and sedation makes it worse. So that, and I don't know. I have not looked at the research on that, and it might even be hard to delineate, but I suspect that when somebody's sedated, they're so flaccid that they don't have the normal neural input to their muscles that they ordinarily would. Because even when you're sleeping, you have tone in your muscles. You have neural input to your muscles. And when you're sedated or paralyzed, you don't have that. So that's what I suspect. And when you have a machine that's doing everything for you, you're just going to completely atrophy. So like Tim said, if somebody's going to be on the vent for 24 hours, even 48 hours, that's okay. And we do get a lot of people like that here in this hospital. I think since this policy was developed, I've only been called down once to mobilize somebody on the vent. I actually got a referral on somebody else, but they were shipped out before I got there. So that's the other thing. This is appropriate for trauma patients who end up on the vent. A lot of those patients, if they come into RED with trauma, they end up getting shipped to Harvard Review or something like that. So we don't see them as much. But in 3 days on the vent, after 3 days on the vent, you start to have cellular breakdown of the muscle cells. So like catabolic changes in your muscle after 3 days on the vent. So that would really be the time, kind of before 3 days. If they're not going to get off the vent within 48 hours, we want to start mobilizing them as long as they can be taken off sedation safely. That's really the enemy of mobility is sedation, like I mentioned earlier. In general, for all patients who are on bed rest, vent or not, you lose about 1.3 to 3% of your strength every day. So after a few days, that gets to be a significant amount. And the older you are, probably the worse it is. I have so many people that just come in, like I had a stroke patient this morning that he just came in yesterday. And this morning he's like, yeah, I don't, his stroke symptoms had completely resolved, but he was not feeling up to his norm just from one night of not doing much. So it doesn't take long. So the early mobilization, so here, the policy here. You want to start with passive range of motion, and I got the range of motion sheet here. Kind of large joints. If they're going to be on the vent for a long time, the most critical of the joints is the ankle, because they get foot drop and those ankles get stuck down. And then when they're better and you go to walk them, they don't have the range of motion needed to be upright, and they end up falling over backwards. So those can be done even from the get-go, the passive range of motion, as long as their blood pressure and, Jackie was mentioning how their blood pressure can tank even with just rolling them passively in bed. So obviously they need to be stable. Their vital signs need to be stable. And then from passive range of motion, you would go to active range of motion. And that's where, so now we need to have, they need to be able to follow directions. So the sedation needs to be lifted, and have them do as much as possible themselves. I mean, that's the definition of active range of motion. So you're really not doing it for them, but you would need to tell them what to do, and hopefully they can do that. From there, then you go to the bed in the chair position, and then from there would be sitting up on the edge of the bed, from there standing, and then transferring and walking. So the role of PT starts when they're going to be sitting on the edge of the bed. So we really don't get involved in mobilizing vent patients until they're to that point where they're going to start moving towards out-of-bed activity. If somebody is going to be on the vent for a prolonged period of time and they are alert and able to follow directions, we can come in and they're not ready yet to sit on the edge of the bed, we can come in and do resisted exercises if that's appropriate. I don't know if we really get those types of patients here. It seems like a lot of our patients, if they're on the vent for a long time, it's because they're withdrawing. And those people, even if they weren't sedated, probably wouldn't be able to follow directions. So following directions is key in order to have, for PT to start getting involved in their mobility. And this policy has, kind of has a red light, green light precautions, which is a nice visual. And the cool thing is that there really aren't that many red stop signs of don't mobilize the patient. And all the ones that are there are also things that are kind of, if the patient had that, you wouldn't think to mobilize them anyway. So for example, if their blood pressure is barely in the parameter of what is an acceptable range, and they're on the highest dose of pressors that they can be, you know, and they start to mobilize, you don't have anywhere to go. If their blood pressure drops, you don't have anywhere to go pharmaceutically to get that blood pressure back up to the normal range. So I mean, that's something that you would go, well, they're too frail to mobilize. Same with cardiac. If say they're on cardizem or something and their heart rate is barely under control and they're on the highest dose of cardizem they can be, you're not going to want to mobilize them because you can't. There's nowhere to go pharmaceutically to keep that heart rate under control. So those are kind of pretty logical. Also, if they're too sedated, can't follow directions, you're not going to get them up. That would be more passive then. And then with fractures, the precautions here, you mentioned pelvic and spinal fractures. The spinal fractures that we get here are compression fractures most often, which really don't have any precautions other than log rolling for pain. I mean, if somebody has an unstable spinal fracture, they are usually getting shipped out. And pelvic fractures are inherently stable. I think in my entire career I've seen one pelvic fracture that had surgery. Just because the pelvic it just has so much inherent stability that you really, even if it gets displaced a little bit, there's nothing that they can do to fix that. So with fractures, it's really more if they have a surgical fracture. So they've broken their hip and they're on the vent for whatever reason, and that hip has not been fixated. You can do range of motion on all of the other, even active range of motion on all of the other extremities, but just leave the fractured limb alone. So, and then with bleeding precautions, I put a little note in here. It says to avoid repetitive exercises to avoid developing hemarthrosis. So what that is, if somebody has an INR that's even above 4 to 5 or higher, if you're going to do range of motion, that repetitive movement can cause bleeding into the joint. So I would have them do things once to, just take their limbs through the full range, but only do it once, so it's not repetitive. If they're doing active exercise, where they're doing it themselves, again, just once and not resisted. Because resisted motion can put someone at risk for bleeding to the muscle if they're straining a lot and their INR is 4 to 5 or higher. So that's pretty well the policy. Now I have the range of motion handout, but really just range of motion is easiest to do when you're doing other nursing care, cleaning them up. If you're rolling them, bend up the hip and knee, it's just easy to incorporate. A few reps is sufficient for someone to maintain their range of motion. Like I said, if they're going to be on the vent for a long time, those heel cords are critical. So you could do those several times a day. And then this other handout, this one page, I like this because it shows, it kind of has the red flags up here on the top, and then there's a visual of the progression of mobility. So from passive range of motion, in bed activity, passive range of motion, putting the bed in the chair position, active range of motion. Then the next one is dangling, so that's where we start to get involved. And moving somebody when they're on the vent is a whole all hands on deck kind of thing. It's quite the proposition. So early in my career, the OT and I would go mobilize people on the vent all the time, and the other person in the room would be the nurse sitting at the desk. It was one of those open ICUs, and there may be one other patient in ICU, and that'd be it. And I think back on that, and I'm just like dumbfounded that we did that without having the respiratory therapist there, and I think we got lucky. But ignorance is bliss. So anyway, yes, it's definitely an all hands on deck kind of proposition to get somebody up. Probably 1 to 2 people to mobilize the patient, depending on how big they are and how functional they are. You want to have one person just to manage the lines in the airway, so that you don't want to you don't want the line to go up above their mouth, because any condensation is going to drain down into the lungs. And then the respiratory therapist, to kind of keep tabs on everything. So, but it is possible to get these vents portable, and once they're sitting on the edge of the bed, you can stand up. Once in standing, I have them step in place, just you want to make sure that they're supporting their weight, and then from there you can progress to walking. So it's really a cool thing. It's just something we haven't done a lot of here, and I don't know the possibilities of having fewer people sedated here. So we're kind of a unique hospital in that regard, in that trauma patients typically get sent out, so we're left with the people who are going to withdraw while they're on the vent. This would be appropriate for people who have COPD who aren't going to withdraw while they're on the vent. So anyway, any patients that it's appropriate for would be really good to get them less sedated and mobilizing, because it'll reduce their number of days in the ICU and help to prevent that post-intensive care syndrome. So from there, I wanted to talk about just mobilization of any patient. And in general, we want people moving 3 times a day, and even that's, if you think about that, it's everyone mobilized, that's not normal, even 3 times a day. But if we got 3 times a day, I'd be happy. So even on the vent, 3 times a day, sitting up on the edge of the bed, in the chair position. The policy mentions 20 minutes of activity, so I think the chair position counts as that, sitting on the edge of the bed counts as that, any range of motion active that's done, that counts as that. So when it says 20 minutes of exercise, don't think that you're doing this for 20 minutes. So we have this handout, you've probably seen this. We just developed it a few months ago for nurses to do on admission. Physical therapy and occupational therapy also has them, so if we find one that's not done, we can do it. And when you're gonna mobilize somebody and have some expectation of what they can do, the most critical piece of information is what could they do before. And you need to make sure you're asking the right question. If you ask them, were you able to walk before you came in? And they're like, oh no, I couldn't even get off the toilet. Okay, could you walk a week ago? Or what was your level of function a week ago? Then you'll get a clearer picture of what their prior level of function was. Were they ambulatory? Were they not ambulatory? Did they use a device? Did they not use a device? All those kinds of things. So that really is the most critical piece of information. And then next is, so what's happened to them since? What's their medical condition? If they have a general medical condition, meaning they haven't had a neurological insult, or they haven't had a fracture or an orthopedic change that brought them into the hospital, we can reasonably expect that they will, in short order, get back to that prior level of function. Because what we're seeing is, say somebody comes in, so 3 days before they came in, they started feeling weak, and then on the day of admission they went to the bathroom and couldn't get up off the toilet. So they come in, their primary complaint is weakness. Well, they're found to have a UTI, and 24 hours after they've had antibiotics, they are well back onto their way to being ambulatory again. And that's because they just lack the reserve for their body to respond to this infection. So there's nothing left. There's no energy left for them to mobilize, which is why the symptom was weakness, even though they have a UTI. The UTI hasn't directly affected their neuromuscular or musculoskeletal system to produce this change in function. It's just a lack of reserve. So that's a case where physical therapy doesn't necessarily need to be consulted, but within 24 hours, see how they're doing. After 24 hours of medical management, see how they're doing. And if they're still having balance issues that are not normal for them, then consult us and we'll come in and do our evaluation. So this form has the prior level of function and then the current level of function, and then you would circle if they should, again, mobilizing 3 times a day, whether that's sitting on the edge of the bed, up in the chair for all meals, or ambulating either in the room or the hall. So it's really easy to kind of this is a quick form to fill out, circle everything, and then as they get better, I actually just cross off the circle and circle the next thing. If they've gone from min assist to standby, I just cross off the min and circle the standby. And then these are posted in this is a quick mobility screen. They're posted in all of the rooms. And the purpose of this is to really help you to feel comfortable mobilizing somebody. So you don't know the patient from Adam. This tool can really help kind of ease your tension about mobilizing them or feeling like there's such a liability on getting somebody up. Now, I don't want you to get hung up on the details of this. It's the overall concept that is the important thing. In fact, we're going to be revising this and taking that right-sided column off of this form completely that says, well, if they're this and this, then you would use this piece of equipment. We're just getting rid of that. So the concept of this is that you do safe things. Have them sit up on the edge of the bed. Can they sit there and be balanced? Okay, if they can do that, then you have them stand up. And how do they do standing? Are they able to stand there? Or are you holding them up? And wherever they get to the fail point, that's where you stop. And standing somebody up at the bedside is completely safe to do, because if they can't do it, they're either not going to get up, or if they're really unsteady, you can just help them to sit back down. You're not venturing away from the bed. And then once they're in standing, if that goes well, then you can have them step in place. And as a physical therapist, I even do that because my muscle testing that I do doesn't necessarily tell me how well they're going to actually do functionally. I have seen people who are incredibly weak and you think, oh my gosh, there's no way they can do anything, and then they get up and walk. And I've seen people who test out strong with muscle testing and they can't hardly shift their weight in standing. So, so even I use something like this when I'm getting somebody up for the first time. So stepping in place, then you know that they can shift their weight. One limb is going to hold them as they shift their weight back and forth. Once they've been successful with that, then you can go to the next step and have them walk. So, just like I said, this is really to help you feel comfortable and confident and not like, oh my gosh, I don't know how they're going to move. So this is totally safe to do. You've established that they can hold themselves up before you venture away from the bed. So, and if they have trouble with that weight shifting, you could still get them into a chair. What I would do is I would have the chair directly against the bed, actually touching the bed, so there's no room for error, if you know what I mean. So if they kind of crimp on you as you get halfway, so they end up sitting on the armrest, well, you can usually get them one way or the other, either all the way into the chair or back onto the bed, if that happens. But I don't like to see it. If somebody has trouble weight shifting, particularly like stroke patients, I don't like to see the chair this far from the bed. So, and always use a gait belt. That's a little note on the side of that form. So, and then the last handout I have here. This is an in-service that I gave to the hospitalists, and it's pretty much about PT referral. But I'm going to kind of go over it with you just. Back to the green sheet quickly. In terms of mobilizing people 3 times a day, our goal really is to normalize their day. So whatever their norm was at home, and I think Tim even touched on that a little bit. So if they walked a household distance at home, walked to the bathroom, they really shouldn't be using the commode. Now, unfortunately, in CCU, there's no bathrooms but you could put the commode on the other side of the room, have them walk to it. That would be more normal for them. And if they're in tele and actually have a bathroom in their room, they should be walking to the bathroom if that's their norm. Now, if they use a bedside commode at home, then use a bedside commode. So, and they should have glasses, hearing aids, whatever is normal for them. We want them to have that and just, make it as normal as possible. That's going to help to reduce delirium. It's going to help improve their mood. If we can kind of make it more like their typical day. And if there's somebody who sleeps until 10, we should probably let them sleep until 10 and not mobilize them until after that. So those are kind of, and that kind of touches on the prior level function. You got to know what normal is for them. And hopefully they can tell you that, or a family member can tell you that if they're too out of it. So anyway, this PT referral handout. So back in 2010, Mayo Clinic came up with a triage system for physical therapy. And then in 2014, Henry Ford Health System took that same publication and kind of tweaked it and made it into an in-service for residents. And then I took it and tweaked it a little bit more, and we educated all of the hospitalists. And we've done an in-service at Known as well. So now we've had some turnover, so not all hospitalists have gotten it. But we try to catch them as we can. So the goal in terms of therapy, physical therapy, is that we're spending our time with people who need the specific skills that we have, and we're not spending time on people who just need to mobilize. So for example, the UTI patient who just needs to get up and move, to normal, and they will recover naturally without us coming in. So I kind of did the red light, green light thing here for hospitalists. When we have an orthopedic patient, that means a surgical orthopedic patient, we actually ask the hospitalists, don't send us orders because we're going to get them from the orthopod anyway. And we need to get them from the orthopod because they give us the precautions. Neuro patients, so strokes, we should get orders on all disciplines should get orders on stroke patients. So speech, PT, and OT, strokes and TIAs. If you happen to see that there's not, we would love for you to pursue, get us those orders. And those are actually core measures, national core measures that speech sees all stroke patients, and then PT or OT. So, but so for general medical patients, which is kind of what this is really all about, because general medical patients, like I said, don't have a primary neuromuscular or musculoskeletal issue that they're here in the hospital for that's affecting their mobility. They have something else. They have a cardiac condition, and the results that we're seeing in terms of their mobility is really just a lack of reserve. So the first thing you want is to make sure that everybody has activity as tolerated orders. This is something that's gotten better since the order in EPIC, order set in EPIC was revamped a year ago or something like that. But still, it's always, actually what I find now is that more often people don't have an activity order at all, whereas it used to be a bed rest order that would flow over from the ED. We're not getting that so much anymore, but it is good to have activity as tolerated orders. So if you find that patients don't have that, please ask the doctor for those orders, or I don't know if you guys can put them in yourself, or so. Anyway, but that's always a good thing to have. People who don't need to get PT orders, people who have, like I said, the UTI, that's what I consider to be a transient decline in function that's going to improve without therapy. So they just need to resume their normal activities, and they'll get better. Somebody who is at their baseline level of function, if their baseline level of function is bedbound, they don't need a PT order. So I actually got one of those ones where somebody used a Hoyer lift at home, and they came in, and when their encephalopathy had improved, the hospitalist sent us orders saying, oh, now that they're improved, we should check out and see how they're moving. And I'm like, they use a Hoyer lift at home. I'm not going to change that. So, and then if their discharge plan is to go to a SNF, and they're going to a SNF imminently, I don't need to see them unless the SNF is saying that they won't accept them until a PT order's been done. And then I can be a team player and do the order. But if they're going imminently, they're going to get a PT, they'd get an eval here and then an eval when they get to SNF, so it's kind of a redundant, not necessary. What I would prefer is that if somebody is going to need SNF level of care, I would have preferred to have gotten those orders on admission. So if somebody has been declining over time at home, say they've had 3 falls in 2 weeks, that's somebody that probably is going to need a SNF on discharge, and I would like to get PT orders from the get-go so we can get started with them, because maybe we can get them well enough that they'd be able to go home and not need a SNF, and if not, then at least we got started on the rehab. And how they were doing at home really, and the length of time over which they've had this decline is really key. If they've been declining for a long time, we're going to expect it to take a long time for them to recover. If they, like the UTI example, if they've just declined over a couple of days, I expect them to come back pretty quick. So, and then the other thing is, if their mobility needs are not complicated, if it doesn't require the skills of a physical therapist, then they should be mobilized by another team member, and we don't necessarily need a PT referral. So people who are appropriate for PT, number one, they need to be able to follow directions and and have sufficient mentation to be able to have some carryover. Now, people who are demented and can't have carryover, we will see them just for kind of family training or that kind of thing, just to, you know, how do you manage them at home? But that would be fairly limited. We wouldn't be there to be training the patient, because that's not gonna happen. And then again, if it's anticipated that they're gonna need a sniff level of care when they leave the hospital, we wanna get those orders as soon as possible. So, and then of course, if their mobility needs the skills of a physical therapist, if they're really unsteady compared to what their baseline is, then that'd be a good physical therapy referral. So, and we've actually asked the hospitalists on general medical patients to hold off on ordering physical therapy until the patient has mobilized with nursing, so that you can weigh in and say, oh yeah, they're getting better, or no, we really need a PT referral. So we kind of rely on you guys to tease that out a little bit. So, and on the backside, there's just a couple of quotes from the Medicare benefit manual. The Medicare manual actually gives an example of somebody with abdominal surgery as one who doesn't necessarily need physical therapy because they came in for this procedure, and yes, they're having trouble moving, but is a real temporary thing, and they should be able to get back to moving normally without specific physical therapy intervention. Because you guys know how to log roll patients, and that's the best way to get somebody who has a big abdominal incision out of bed and that kind of thing. So, does anybody have any questions or? Yeah.
So sometimes, not very often, but sometimes we'll get a patient like with a pelvic fracture or a compression fracture, and there will be spinal precautions. I think that's what I've seen before, is or spinal fracture.
Pelvic fracture?
I don't remember the exact fracture, but when they say spinal precautions.
Maybe compression fractures could be, that's fine.
Yeah, so spine, and was that from the physician, or was it in our
No, it's a
documentation?
physician thing.
Okay.
But finding a policy here, or even what that means, is it log rolling? pretty
That's
much?
how I interpret that.
Okay.
Is that, and for the most part, pelvic fractures and compression fractures, that's what we teach them, is
Okay.
log rolling.
Okay.
Now, pelvic fractures, they just have pain no matter how you
Right.
mobilize them. It's, so, but log rolling is the best. There's the least amount of torque, you know, on your spinal column and doing that. So that's how I would interpret that. Sometimes abdominal binders can help with pain. But yeah, pelvic fractures especially
I think
are
I've
just,
only run into that twice, but I was looking on the internet even, looking for
Spinal.
what exactly does that mean?
that's how I treat it when I see something like that, is just, okay, that means I'm gonna log roll them, which I would have done anyway probably.
Okay.
I mean, if somebody has an unstable spinal
They won't be
fracture,
here.
they're not
They'll
gonna be
be
here.
shipped, right?
Right, yeah.
That's why I was
We
kinda
don't
like-
put people in halos and that kind of thing here.
Right. Right.
So, yeah, that's major.
That's kind of how I took it.
Right. So, and in terms of Epic, I think that's probably what it actually refers
But I
to.
don't
So it's
think-
probably not used appropriately
Yeah, and I
here.
don't think it was a nursing communication. I believe it was a clicked. something
Okay,
that
was this
clicked.
recent?
No, about a year or two.
Oh,
ago.
okay,
It
okay.
was not.
Because we did have somebody recently that had, I don't know that it was specifically a compression fracture, but they had a vertebral fracture, maybe upper lumbar. And the physician decided that it was unstable, and he ordered the person to be on bed rest until they got a TLSO, a brace. So I mean, technically in Epic, I think spinal precautions would refer to somebody who's had, you know, a cervical fracture and they're at risk for being a spinal cord injury, or they are a spinal cord
Okay.
injury, that kind of thing. But,
Okay.
so when it's checked off here,
And it didn't even give like on the right a little explanation or, yeah, it was kind of like, what is this?
yeah,
There's
so
things in Epic
that
I
was
don't see.
probably, checked not, I mean, it was used not how it was intended to be used.
Okay.
But, so when I see that, and I know they're a compression fracture or something, I just know that I'm gonna be doing log rolling anyway.
Okay.
That's the least painful way to get them up. Now, that doesn't mean it's not gonna be painful, because
Right.
pelvic fractures are painful with everything.
Can you turn them on the affected side or only on the unaffected?
They would be less painful, pelvic fracture, they'd be
Uh-huh.
less painful if you turned them on the unaffected side. But I mean, I use pain as my guide for everything in that regard. So, and sometimes the least painful way to get them up is to skip the log rolling, crank the head of the bed up. You have to keep the lower part flat so they're not climbing out of a hole, and then so they're almost already sitting, and then just turning them. So, using the pad underneath them, so you're really not changing their position.
You're twisting.
You're right, exactly, and that takes two people to do, one
Yes.
person in the front with the pad and then
Yes.
somebody behind to move their, and you're just moving them like they're just fixated in that position. So, kinda you do what works with the compression or pelvic fracture,
Thank you.
so. So I think it's always good to have a discussion about sedation with people on the vent. We can go back to that, just because I don't see that many people on the vent, so I don't know, I mean, like, what's the average time we have people on the vent here?
It varies from
It varies.
patient to
Yeah.
Usually
patient.
less than 7 days.
Yeah, that's what I was thinking, we
Less
don't
than-
have
less than a
that,
week, yeah.
we don't have that many that are like long-term.
If it's more than a week, then, they put a trach on and then they transfer the patient. to
Right,
another
I've
facility.
never seen anybody with a
So
trach
usually
here.
less than a week,
Do they do trachs here?
yes.
Put them in.
Oh,
And then we
okay,
transfer the patient to a long-term, to, what is that place called?
Kindred?
Kindred.
okay,
Sometimes we get them with a trach and we'll have care, but often they're really well educated on how to care for their own trach, depends upon how
Was he-
sick they are.
That's a chronic.
so that'd be somebody who was a spinal cord injury from before.
Maybe.
Yeah, that's a chronic one.
Okay. I don't think I've ever seen anybody with a trach here, even
A
one that
trach on a
had.
vent especially, we don't see a lot of that.
No.
They can vent from a trach, but I don't think we even do that here, do we? Have we done that?
Oh,
You mean
we have,
Acute phase?
yeah.
Yeah,
The
the acute
acute
phase,
post-op.
yeah, we do, but then, if they think that, it will take a long time to extubate them,
Yeah.
to
Yeah.
get them off the vent, then we send them to Kindred,
Right.
yeah, for
Our-
long term.
Our sedation, Tracy, is directed via the RAS scale.
We have a
Right,
The-
remember we
the-
talked about that.
Yeah.
Yeah, and so the physicians indicate to us where they'd like that to be, but sometimes the patients direct us where they're,
Comfort level is?
right, and sometimes it's not a possible thing to, and then we have to go back to the physician and say, we can't do a -1 to -2 RAS, we might need a -3,
Oh.
because they're continually bucking that ventilator, working against it, and so it's
Like
a
they're
fight.
breathing more frequently than the ventilator, is that what you mean by that?
Well, they're
Coming
they're,
up
they're fighting it.
asynchronous.
Yeah,
Yeah.
sitting bolt upright,
asynchronous.
looking at you, pulling it out,
Okay.
with
Right.
your hands tied.
Yeah.
So, yeah, that would, I
And
can't,
the
I
negative-
can't
and the
imagine what it's
negative-
like
and
to
the
be in
negative
that.
score is a deeper sedation level.
Okay,
Yeah.
so, obviously people don't, it's not like they are sedated and then they're awake. It's more of a
Depends on
gradual.
the drug.
Sometimes.
Right.
Oh, okay,
The drug falls pretty quick.
okay.
Depends on the case too.
And the patients.
The patients too, if they are withdrawing from alcohol,
Right,
we
and,
want them to be,
right, and that's somebody who wouldn't be appropriate to
Yes.
mobilize when they're on the vent
Definitely.
anyway, because
Yeah.
even if they weren't on the vent, they're not appropriate to mobilize, they're not following directions well enough. That's somebody that we need, yeah. Yeah, when I get orders on somebody who's actively withdrawing, I just put them on hold, let me know when they're done withdrawing, and then I also want nursing to have mobilized them when they're done with the withdrawal, because maybe they've gone back to their baseline.
Yeah.
So, I mean, nobody is steady when they're drunk or withdrawing. Nobody. So,
and most of our vented patients, the population is mostly elderly. We only get the young ones, when they are drug related.
right.
But
Sometimes
mostly
there's,
elderly.
status
Asthma.
asthmaticus.
Sometimes, yep.
But yeah, generally speaking, it's an older population. Or it could be a pneumonia and it's developed into ARDS. That's when we see a younger
And
population.
that's the.
And they're unstable. They're pretty
Oh,
unstable.
they're too unstable to have the sedation lifted?
Well, it